Welcome to Inside Aesthetics, the world's leading podcast for injectors and aesthetic businesses. I'm Dr. Jake Sloan, an aesthetic doctor with over 16 years experience in facial aesthetics.
And I'm David Siegel, an entrepreneur and business mentor with over 20 years of experience in our industry. Our podcasts are aimed at industry professionals, and any information or advice given is general in nature. You should consult with a healthcare provider before undergoing any treatment.
Morning, buddy.
Hello.
You're back with me again.
We're here. We're in the podcast studio. Double whammy today.
Yeah, we've done one already. This is number 2 for the day. What's happening in the Patreon world?
Patreon is growing crazily.
Yeah.
A lot of new members. I think it's got to do with a lot of your travels overseas. We're mentioning it now in almost every podcast. So it seems like every day there's like 2 or 3 new people that are sort of coming on board or taking advantage of the 7-day free trial.
Yeah.
So everyone would have seen the episode I did last week with Dr. Felix on how to attract more patients. Within the next few days, I'm going to be recording some content on, I guess, a bit of an idiot's guide, in inverted commas, on what you should or shouldn't do before considering purchasing a device and bringing it into your practice. Because I get that question a lot. I want to buy a device, and then my question is, well, why? How have you identified you need it? Have you done a business case study for it? Do your patients actually want it? How are you going to finance it? Blah, blah, blah. So I'll be covering all of that to give people some, bullet point thought processes to go through before they start parting with their hard-earned cash, especially in this economy and all the competition. It's getting harder to make dollars. So I think spending money wisely is very important. What have you been doing?
Well, we've got 2 new offers, IA offers to announce first of all. So you guys would have known Rick O'Neill from LTF, Look, Touch, Feel. They're a digital marketing company based in the UK. But now, excitingly, they've got a staff member here in Australia as well to support clinics with their digital needs. So if you want to get some background to that company and the types of things that they can help you with, Rick did our mini-series called the Digital Deep Dive, and that was episodes 193, 197, 202, and 210. But basically, it's stuff like Google and the back end of your SEO, website building, automation, and all that kind of stuff that none of us doctors or injectors know anything about. So they will help you with any of that kind of stuff. And of course, it's our typical offer of 10% off any of their services. All the information on how to get looped into their company and how to contact them is obviously down below in our description. The other one with a company called Ultrana Medical.
Yes. Yeah, and we've had the owner of that company on in the recent past, Stuart Turner, who I think he was formerly trained as a physiotherapist. Yeah, and so he owns and runs a company that does sells ultrasound, does education courses on it as well. So they've partnered with us as well. Again, standard offer, 10% off by quoting the code IA. And of course, you can see all of our offers by going to our website and looking at our offers page, which has everyone in there listed. We're going to be changing that soon, but that's how you find it for now.
Correct. And also, as part of that offer, Stuart is actually holding an in-person course May 4th here in Sydney, and you also get 10% off that if you go through the offer.
Excellent.
There we go. So let's introduce our special guest of the day. It's our old friend and alumni of the podcast, Pene Timberlake. Pene, how are you today?
Hi, I'm good. Thank you for having me.
And he didn't mean old by age. He meant old.
No.
Yeah, I was like, come on.
Old in terms of historical. We have been friends for a long time. In fact, I was looking back at when you were first on the podcast, Pene. What episode do you think you first came on? What number?
I think it was in the first 20 or something, wasn't it?
You were actually on number 3.
Oh, wow.
And then you came back on 26, and then your third one was 43.
Oh.
It's been a couple of hundred since then.
Yeah, and it's interesting because what we're going to talk about today kind of circles back to what we originally spoke about over 5 years ago. And we want to learn about your path and what you've been up to in that last 5 years, but also, I guess, where we're at as an industry and as a specialty, because it's all come full circle.
So would we call this an advanced Injector Diaries episode? It could be.
Yeah, kind of a mixture of Injector Diaries as well as what the hell is going on in Australia, I guess.
So where do we want to start with this? Do we want to start with what's going on in Oz?
Well, let's preface and introduce Pene back to some of our newer listeners and just give us the story of you know what your background is and what you do day to day, Pene, and then we'll talk about your newer qualification and what that means and some of the challenges that maybe you encountered on the way, and then we'll get into the regulatory stuff.
Okay, I am a nurse practitioner in the dermatology space, which means I started as a registered nurse about 20 odd years ago in emergency and theatres. From there, I stumbled across the cosmetic industry, and since then I've had a pathway that's taken me to commercial, working for some of the big brands like Candela Medical and Allergan, through to clinic management, through to education, clinical specialty, in and out of practice, back and forwards, and now in dermatology for the last 6 or so years. So very varied, but a lot of that has sat in that aesthetic space, which has been a great adventure, let's just say.
Well, Pene has abbreviated her whole life there, but I can tell you she's one of Australia's and probably, I would guess, one of the world's most experienced nurses and now nurse practitioners. You've done every role
in this space
under the sun, yes, in terms of aesthetics, of course. Yeah. But, you've done everything from working for a laser company and developing teams, and you're now an Allergan faculty trainer for the nurse faculty as a KOL. You have trained all sorts of injectors, probably thousands over the years. You've worked in recovery. You've kind of done it all. So, you've got a wealth of knowledge. And if you want to hear Pene's full story, that's back in episode 3.
Oh, I wish you'd introduce me like that. He's like, this is Dave. He's run a few clinics.
No, it's rubbish. Rubbish. Just chat shit behind the microphone every Friday.
Oh, no. Clearly I have a short attention span, moving from one thing to the other. But that's the fun thing with medicine, right? We can move and shift, and there's so many opportunities in different spaces. So it's a great industry from that regard.
When I first met you, you'd just come off a plane from Harley Street, which is kind of where it all started, really, wasn't it? I mean, Harley Street was like the street of where aesthetics happened under the cloak of darkness.
Absolutely. It was exactly that. I came to Australia. I thought, gosh, this will be easy. I'll start a clinic and it'll be great. And then realised that the Australian market was incredibly different to the UK market. Australians wanted different things. It was treated very differently. And so I kind of started on that path of, seeking to understand, which led me to the pharmaceutical industries, which was great. I had fantastic exposure to many great injectors, many movers and shakers. I had a lot of advanced knowledge given to me, and it really set me up, I think, for where I am today. So for that, I am really grateful.
Yeah. And what's motivated your shape-shifting career? Because you've worn a number of different hats, obviously still within this space. So I guess a lot of people might be wondering, what's your thought process been throughout this, very sort of successful career, but you've sort of done it in a number of different iterations. What's the plan been, and what's motivated those changes?
I'd love to say that there's been a plan. I think it's more what takes my fancy or where I find a new interest point. So for me, you just keep growing, and I love learning. It's just something I've always enjoyed. So if there's an element to self that I don't understand or that I need more knowledge in, I have a tendency to lean into that, which means, shifting into different roles and, wearing very different hats. So, I also feel that the aesthetic industry is very commercial, and not having a commercial understanding is not helpful either. So for me, jumping it back and cross, and also in the pharma industry, they have a very different take on how they see the industry and the growth factors and what's happening there. So to give balance to my thought processes, it's good to kind of go through all of them and, have experience everywhere.
Yeah, I think it's really good to have that perspective. Tell us about your day-to-day practice now. Like, where do you work? What are you doing day-to-day? Are you doing lasers as well as injectables? What's your scope of practice?
So I work at the Northern Sydney Dermatology and Laser Clinic, which is in Northbridge in Sydney. It's the largest private dermatology practice, I think, in New South Wales, if not further on. We've got 11 dermatologists that work for us and a team of about 40 staff in general. So we're pretty decent size for a private practice. I work in a dermatology scope, which means I see patients on my consultancy list that have acne, that have scars, that have rosacea. I also see aesthetic patients. I also help with dermatology lists. I do biopsies. I order investigations. I look at pathology. I help with wound care. I use lasers. So I've got a very varied practice across my day-to-day kind of scope. And on top of that, as you said, Jake, I also still work for Allergan as a faculty member and trainer. So, every couple of times a month, you'll see me training aesthetic injectors or giving lectures on either anatomy or consultation or whatever it is that the need is within that practice. So, yeah, that's kind of where. And then the other days I'm a mum. So that's kind of, the full-time unpaid side of work as well. So I work normally around 3 days a week throughout those areas.
Yeah. And also a wife.
Yes, of course. Oh gosh, forgot about that. That might.
So you sort of drew an interesting distinction there between aesthetic patients and treating patients with rosacea and acne. Where do you sort of see that delineation where someone with rosacea or acne scars differentiates from someone that wants to come in for some anti-wrinkle treatments? How do you sort of say what's aesthetic and what's not? Because to me, I think it's all aesthetic, but I'm curious to know what your thoughts are.
I love that question because I think it kind of really looks at the problem with the aesthetic, medicine. You can't differentiate them. And the reality is generally people don't die from acne or rosacea. They come in because they're unhappy with the look of it, but it is considered a medical indication. And I guess that's based on evidence. It's based on protocols. It's based on years of study. It's based on understanding the pathophysiology behind it. So for me, most people come in with a medical indication, but they do want an aesthetic outcome. And that's really what we're working on. And I would have to say in the practice that I do work, that's really accepted and acknowledged and celebrated. So most of our patients will walk out medical indication, treated, aesthetic outcome. So they're happy with both sides of it.
Yeah.
So yeah, it's, I don't think there's a massive differentiation. I just think probably our understanding and acceptance of medical dermatology is a lot clearer than aesthetic dermatology.
What do you think, Jake? I mean, because what's the difference between a wrinkle, which is not going to kill someone, but it has an aesthetic appearance, it can affect someone's self-perception, their psychology, their general well-being and mental health, versus someone that's got severe acne scarring?
Well, look, firstly, I don't manage those patients in my clinic, and I would refer to Pene because her practice is probably a couple of miles from mine, so it's quite easy to cross-refer, and, you sometimes send some of your patients to us. I guess the psychology of these patients is often different, and often, especially things like acne, they may have been affected in their teens or around their age, and so the patient's sort of motivation is possibly different. They may have been, God knows, bullied or just be more self-conscious at an earlier age, whereas, many of our pure aesthetic patients come in their 40s and it is, even by the own patient, sometimes seen as a bit frivolous.
Yes.
So, yes, it's all aesthetic superficially, but the pathophysiology is obviously different.
Correct.
So yeah, I mean, it's all aesthetic, but it's slightly different patient, I would say.
Yeah, interesting. I guess you're looking at acne, it's something that shouldn't occur and shouldn't cause scarring, whereas getting a wrinkle is just a natural accepted part of the aging process. Maybe that's a way of looking at it. But it's an interesting discussion piece.
Yeah, definitely. I mean, that's a good point. How do you approach those patients differently? Do you have a different consultation process? Do they come in different clinics and different days, or are they all lumped together in one thing?
Yeah, no, they come in. The consultation process is the same. The assessment process is similar. You need to look holistically at your patient and see how they're dealing with or accepting of or not dealing with the indication in front of you. So my list might have 2 acne patients and then 2 aesthetic patients and then a scar patient and then a rosacea patient. And I wouldn't say lumped in all together, but I think the process of medicine is similar, right? It's a consultation process. It's understanding the patient's needs. It's assessing, it's investigating, it's figuring out that differential diagnosis and putting a treatment plan together. So my consults are very similar across both, to be honest.
And how do you deal with the psychology of a patient that has potentially been impacted by childhood acne? Because I mean, I know people in my life that have been affected by that, and it does have like a long lasting effect on someone's self-perception, their confidence. And so I guess when you're being presented with people like that, I'm assuming you're acutely aware of those psychological impacts, but just curious, do you have sort of a team that you sort of refer to? Do you sort of work within a sort of an environment where you've got other people that take care of that side of things, particularly with those patients that have maybe got those issues that, haunted them when they were early in life?
Absolutely. We've got a referral process externally for psychologists that we can use. We also work really closely with the GPs to make sure that they're holistically looked after. And sometimes it's even speaking to family members and things, particularly they're a younger patient, just to make sure that they have support around the process of healing. So you're absolutely right. Acne is well evidenced to affect people's mental health right through their lifetime. So, and we ask the question, where are you with your journey? Where are you sitting with this? How is this affecting you? And really getting comfortable with those uncomfortable questions, I guess, is really important as well. So we've got a really great view of where to start from and how well we can meet the expectations of the patient, depending on the procedure needed.
So, Penny, you mentioned your scope of practice is quite different to, I guess, a registered nurse. And when we had you on 5 years ago, you were a registered nurse. So what's happened since? And we have had a couple of NPs on from different countries. But what does it mean to be an NP here in Australia? And how did you get that qualification? What did you have to do?
Yeah, so a nurse practitioner, it is a protected title in Australia, and it's the highest level of clinical nurse within the Australian medical system. So we are basically endorsed registered nurses, which means that we work at an advanced practice level, and it allows us to request diagnostic investigations, it allows us to prescribe medications, and allows us to receive and make referrals as well to other practitioners. So it's a different level of registered nurse, but we are, in essence, registered nurses who have become endorsed, making us a nurse practitioner. The pathway is very clear from AHPRA's perspective and from the nurse practitioner's perspective. You start with your Bachelor of Nursing, which obviously everyone starts with as a registered nurse. The expectation is then for you to do a new graduate year within a hospital setting or a clinical setting. From there, you move into a specialty area of practice, and I'm sure we'll talk about this a little bit later, but aesthetic medicine is not considered currently a specialty area of practice. From there, you need to complete a postgraduate study, so a certificate in your area of specialty. So for that, for me, was a postgraduate in dermatology, which I did through the Australian College of Nurses. And then from there, you need to complete 5,000 advanced practice hours. So if you can imagine in a hospital setting, we might call those nurses clinical nurse specialists. We might call those nurses clinical nurse consultants, but at a high clinical level. And then from there, you need to do your master's, which is a 2-year program through a few universities in Australia offer this, but it must be an NMBA approved, so Nursing Midwifery Board of Australia approved course. And I think that's where a few of our colleagues going through have probably come undone as well. So not every university who offers this is an approved program through the NMBA. Then you apply for your endorsement and you wait and you see if they accept that your CV and your clinical practice puts you at a high enough level to consider you a nurse practitioner. So you can finish your degree, you can finish your master's and do your postgrad. That still doesn't mean that you'll become endorsed to be able to use the term nurse practitioner. Within that space as well, you have to be not only be able to show that you're at an advanced clinical level, but you also have to showcase that you have leadership and management experience, that you have education and research experience. So they are really looking for somebody who's quite well-rounded, who's had a lot of experience in lots of different areas of medicine, but more importantly, within one specialty that they can follow that pathway through to see that translation from junior to senior to advanced and then into that NP space.
And what were your motivations for putting you through this rigorous, I'm sure very time-consuming and at sometimes infuriating process? What drove you to do this? Because you're already very successful, registered nurse, lots of years of experience, more clients than you can probably poke a stick at. So what was the motivation for you?
I just wanted to learn more and I wanted to become a better nurse.
Yeah.
And I think we forget about that. Within our careers, we jump into one specialty area and we want to become really good at that thing. So becoming a good injector. For me, 5 years ago when we spoke, I was working for Candela Medical, which was an incredible role. I had a massive APAC footprint. So I was traveling a lot. So most months I'd be on a plane internationally. Once or twice a year, I'd be over to Boston, although that was fantastic. And I loved what I learned. And I was very much involved in the dermatology space and working with incredible KOLs. It was really hard on my family. So it was really about trying to find balance. And when you get to that stage, I guess, in a corporate career, you either go, do I go higher, which is your more MBA and looking at your more business protocols, or do I really lean into that clinical aspect and see if I can find some balance? And for me, that was the right choice for myself and my family. The other thing too is when I was working with Candela, I was exposed to so many different indications in dermatology that I hadn't been before. So I had a general understanding of pigmentary disorders and vascular lesions and things like that. But, it was a very superficial understanding and I loved it and I wanted to understand more. So taking that clinical pathway and coming back and redoing a postgraduate in dermatology really enhanced my practice there. And that also led me to meeting the girls at Northern Sydney Derm and Laser. So 2 fantastic principals, now 3. I would go in there and train them on new indications and talk to them about these vascular anomalies and, pigmentary disorders. And we would talk about the different lasers and the way that we could use them in an advanced way. So they just said, look, if you ever get sick of corporate, we'd love to take you on. So they employed me as a nurse practitioner candidate. So I went straight in within that role. which was fantastic. And they've really mentored me and helped me advance my clinical skills even higher than where they were, which has allowed me to move into this clinical space. And it's been fantastic. I've been really lucky from that regard.
So to summarize an NP, you choose a specialty. Yours is dermatology. You obviously do a lot of extra training, university work, et cetera, and experience. And then you eventually qualify with a master's. So yes. My understanding, and you alluded to it, is that the pathway to cosmetic NP doesn't exist, or did it used to exist and it stopped? What has happened? Because 5 years ago, there are a lot of nurses who declared, I'm going to get my Masters of Nursing so I can be effectively an autonomous injector who can script for myself, manage patients myself. And it was seen as a sort of pathway to freedom or independence, if you like, and that door has shut now, as far as I understand. So explain that background.
My understanding, and again, I didn't do it 5 years ago, but 5 years ago, the pathway probably was a little bit less unclear in terms of the way they regulated it, or they outlined it. So anyone who did a master's degree could call themselves an advanced practitioner. And I think probably from a regulatory perspective, they weren't really looking at aesthetic nurses. And to be fair, if you put yourself through a 2-year master's, good on you. Your clinical ability is going to be a lot higher than someone who hasn't. So I think that was really the thinking. You've been nursing for X amount of years. You've done your master's study. You're at a high clinical practice, and we trust the endorsement process, and that's where you're at. Mm-hmm. Whereas now, I think with the distrust and change in the industry and the fact that we can't really define it, AHPRA have gone, well, if you can't define your own industry, how are we supposed to define it as advanced practice? So they've downgraded it from advanced practice to an advanced skill. And an advanced skill is very different to a holistic practice, which involves that diagnostic ability, assessment ability, investigative ability, and then treatment planning. So they feel at the moment that we don't meet that criteria for advanced practice, and therefore you cannot become an advanced practitioner in an area that doesn't qualify as advanced practice.
It kind of makes sense. We've squabbled about this for years, but we don't have a qualification. So how can you have a nurse who has that qualification if we can't even define what an injector is?
Yeah.
Makes sense,
yeah,
right?
Fair enough.
It kind of does. And we've just done ourselves a bit of a disservice in that race. In saying that, there are cosmetic diplomas and certificates that you can do, which would then lead on to master's study. And I think what's really sad is there's a lot of fantastic registered nurses who have gone out and done these diplomas and postgraduates and gone on to do university study, only to be told halfway through their journey or at the end of their journey that, sorry, we've downgraded aesthetic medicine to a non-specialty, and therefore you now are not eligible for the endorsement process. So there's been a lot of, I probably get weekly phone calls, messages, or, DMs from nurses who have gone through this whole process only to find at the end. So where they started and where they ended up, two very different journeys and very different understanding of the aesthetic space from AHPRA.
So had those nurses defined a pathway like, I don't know, cardiology, gastro, or a specialty, or were they only aiming for aesthetic?
Most of them were only aiming for aesthetic. However, they've even become more harsh on how they look at nurses who have any background in aesthetic medicine. So when I went through this pathway, 100% of my clinical hours were dermatology related. So medical dermatology, not aesthetic dermatology. Yeah. 100% of my mentorship hours were dermatology. My postgrad was dermatology. So all of that was in my CV. And yes, in my CV, there was a portion of aesthetic medicine. So what I was told when I put in my application was that it was likely to be unsuccessful because I couldn't prove advanced practice, because they Googled me and saw that I also did cosmetic medicine. And I said, well, that's not a secret. That's on my CV. I wrote down that I do cosmetic practice, but none of the hours included on there were, aesthetically derived. So I don't understand where the problem is. So what they said to me is, you need to prove to us that you're an advanced practitioner. So it was up to me to then gather a whole lot of information to prove to them that in a medical space, what they defined as a medical specialty, being dermatology, was real, current, and supported by those around me. So I got 7 letters of recommendation from different dermatologists. I had Phil Becker, who's head of laser dermatology for the Children's Hospital, write a letter explaining laser and its medical usages, and that is an advanced specialty in itself. I then had to get my work to say, yes, Pene does cosmetic medicine. However, she also does this in dermatology. So it was quite an arduous process to prove to them that outside of medical aesthetics, I'd done my time as an advanced practitioner in dermatology based on, my background and history. And it was really nerve-wracking. It was a horrible experience to think I tried so hard and worked so hard to get these qualifications, to then have someone say to me, well, we might not let you through because I Googled you and you do aesthetic medicine. And I wholly believe that aesthetic medicine is a specialty in its own right. I wholly believe that we use the assessment, diagnostic, investigative processes for this, for our patients. But at this point in time, until we get clear on that and have clear protocols and guidelines, it's hard to prove. And therefore, you've got to rely back on your, I guess, more medical or more understood pathway. And if you think about it, if you went into, I don't know, like ED, it's pretty clear cut, right? You've got standardized protocols that you work to. You go in as a junior nurse, you do your time, you do your postgrad, you become a CNS in emergency. They understand what that means. It's very clear cut. Your pathway is very clear. And therefore, it's very easy for AHPRA to say, we know what you've done. We know you're at advanced practice because we understand that process. Private medicine's not well understood. So it's not just aesthetic practice. There's a lot of private practice medicine that, probably doesn't have as clear pathways, making it more tricky for them to define, to then put an endorsement to.
I'll ask you a controversial question. Do you think that within the regulators, there is a kind of a negative bias towards what we do? Or do you think, just like you said, it's just hard to define, so they have a blanket rule of saying, well, we can't endorse you when you don't have a syllabus?
My personal feeling is there is a negative bias, but I feel that negative bias comes from the fact we haven't defined it ourselves. So, we've moved so quickly in this industry and things have changed so much in the time that I've been in it that we argue over it, right? Like we argue over who's an advanced practitioner and what does that mean? And are you advanced because you're doing temples and tear trough, or is that just an advanced skill? What makes you advanced in this practice? Is it because you've got a big Instagram following? Like AHPRA don't care about that. So, what is it that defines us as advanced practitioners, and how do we prove and show that? So I think there's always going to be a negative bias towards it based on the fact that we just, we haven't sat down and really thought about it and put guidelines behind it to prove and showcase that we're a serious medicine.
Yeah.
When you say we, who's we? Because we've got doctors, dentists, nurse practitioners, registered nurses, enrolled nurses. We're a sort of a big melting pot of different areas of medicine that all undertake treatments within this industry. So how do you see us actually defining who we are and what we do, and what's that path look like? Just your personal opinion.
I feel that every aspect of this, we do need to work together, definitely. But I think there's different protocols and, key performance indicators that work for each subsection as well. So you can't expect a nurse to have the same, I guess, guidelines as a plastic surgeon who does non-surgical. So I think we have to sit in our own areas and really define what that looks like for nurses, for NPs, for GPs, for specialists. And then we need to come together and agree that that is a pathway that we all agree on. I think New Zealand's done this quite well. Speaking to Sarah Hart, I know in New Zealand you've got to do a diploma program as a GP to be able to access insurance, for example, to do, aesthetic medicine. So they've worked so hard to get that pathway in place, and it's great. But we haven't done that with any of the pathways here. We've got, courses that are available, but, who regulates those and who says that they are the right way to do it? And everyone seems to feel their course is better than someone else. So long-winded answer, I think we all have to take responsibility for our own profession, but at the same time then have an agreement across that level at a higher level, as well.
Yeah, we were going to try and escape going back to regulation, but here we are. We're going to talk about regulation. So, there's obviously lots of changes happening, and they've been bubbling away for a couple of years. And obviously last week we had that raft of three major changes that we referenced in last week's podcast. But where do you see this happening? It seems to me that the net is tightening around all of us, but nurses, doctors, and injectors, and our scopes are trying to be defined by the regulator and what we can and can't do. So where do you see things going? Do you think that we'll eventually have I don't know, do you think nurses will be allowed to inject in 5 years' time? Well, is that where's AHPRA going with this? I don't know.
They have to start somewhere. I mean, we're not in a great space, let's be honest. There's no protocols around it. Patient safety is an issue. We have to stop and just really think about what we're doing. It is really interesting from a nurse's perspective that, our nursing and midwifery board don't see aesthetic medicine as an advanced practice, and therefore we can't keep endorsement from it. But I know that's not the same from the medical perspective, because obviously there's many doctors who only practice in cosmetic medicine and injectables, and they don't have their, their registration or endorsement threatened. So we're not even, across the board happy there. But if you think about it, 20 years ago when I started at Harley Street, it was very much practitioner-led. The patients would come in, they'd sit down. Generally, the doctors, there was some nurses who injected, but mainly doctors would say, this is what I think we should do. We were very limited on what we could do back then, but, it was very much practitioner-led. And then if you think 10 years ago, we had this massive shift for it being completely consumer-led. And what I mean by that is, literally patients could go onto a website and say, oh, I've decided I want to get my cheeks done, and I can pick that option. And they walk in and they say, I want this. So then we went this whole way of being completely patient-led. And we've got to find balance with that. And I think that's what AHPRA are trying to do is they're actually kind of helping us bring this back to being a bit more medical, because what they're saying is you need to now align with the rest of medical practices. But, nowhere in your right mind, Jake, if your child woke up with a sore throat, would you go, oh, I'm going to go onto a website and see who gives out penicillin. Mm-hmm. And if they give out penicillin, I'm going to go and see that doctor and walk in and say, I've decided without even looking at my child's throat that they have strep throat and you need to give them penicillin. But that's what we've done in our industry. It's so consumer driven that we've lost that art and that investigative piece of assessment and consultation, and our patients don't respect that anymore. So I kind of think AHPRA have missed the mark in a few areas. Yes, it's not necessarily about patient safety, but they're just drawing a line and kind of saying we've got to bring this back somewhere. So in some areas I agree with what they've done. I don't think they've hit the mark in patient safety, but I can absolutely see why they're cutting out what we can market, what we can say, and how we advertise, because we've turned this into a consumer-driven medicine as opposed to it being a practitioner-led educational medicine, which is what it should be.
Obviously, we've got listeners in other countries and injectors in other countries, and we've kind of done the regulation stuff to death. But I think it's really important to reflect on your own practice. And for those countries where they don't have regulation, UK is a good example. Can you try and explain to those injectors why it might be a good thing to follow this path that AHPRA have sort of put out for us? Because when I speak to other injectors around the world, they think it's mad here. They think it's crazy. They think it's nanny state. They think it's, they don't like the idea of being controlled. But there are some positives, and you just mentioned bringing us back to the medical model. So
I don't think it is being controlled. I think it's actually about giving us more control as practitioners. I think it's about having patients coming and seeking consultation and seeking a partnership and seeking education. So, that's what I want for my patients. I don't want them coming in going, I've already decided I want a Big Mac. Thank you very much. Can you give me that with fries? No, I want them to come in and say, hey, these are the areas of my concerns. And what's your medical opinion based on, the 20 years of research and time I've put into this industry. And then through that, my job is to empower them to make an educated choice. And that's how it should be. So I actually think the opposite is true here. I think guidelines in some respect actually give us practitioners more control as opposed to taking it away. I think we're taking it more out of the consumer's hands and putting it back in medical control by doing some of this. I don't think it's a bad thing at all. That's probably a really unpopular opinion, by the way. You'll never want me to come back again. But from that perspective, I don't think it's a bad thing at all. I think it helps with patient safety. Things go wrong. Like, we're seeing it all the time. And being that I work in a dermatology practice, we're constantly seeing patients who have had poor results, bad outcomes. That can be aesthetic, or it can be bad outcomes because they've got late onset infections, they've got nodules, and, poor medical history taking, poor placement of product, poor choice of product. We see these things quite regularly. So the ethos of medicine is to do no harm, yet we're consumer driven. They come in and tell us what they want, and we're not putting patient safety first. So guidelines are supposed to help. And I think when we get them completely right, we're in the middle of trying to get these right. I think it'll be a good thing for the industry in whole and great for our patients.
I'm actually with you, Penny. The more I've thought about this, the more I'm in line with what you just said. I think the only thing that the pushback is the basically you can't advertise on Instagram. That's what seems to have irritated people the most, because of course directly that affects their business. Their primary means of communicating has sort of been chopped off. So I understand the frustration.
Well, you can value yourself as an amazing practitioner. You can talk about your value sets. You can talk about your experience, your ethos, who you are. And then what you're trying to do is bring people into the clinic who think the same as you and who want that valued opinion. So, yes, I think that's one way that we've advertised, and we've been lucky it hasn't been an expensive way, and it's been really successful for a lot of our clients. But it doesn't mean we can't do that. But it's more about, again, them seeking educational advice, and we can talk to education, and we can put so much on that. That isn't just I want a lip treatment and a cheek treatment, please, because that looks nice, and I think I want that as well. I think we can still advertise in different ways, but again, make it more educational and still be in line with what APRA is saying. And what we really want is patients coming in and having a good consultation where we can focus on education, and that's great as far as I'm concerned.
Yeah, I agree. I think it gets back to the awkward question of, do we have too many injectors who aren't fully invested in the specialty? They're there for other reasons, like making a buck. Like, I know that's controversial, and some people might find that sort of hard to listen to. But if the bar is low and patients can get what they want, and injectors can just throw out what they like and offer cheap prices, maybe we do need to reset things. I mean, it's just.
I think there's a bit of that. I would like to think that the majority of injectors I go and see, particularly from a training aspect, the majority they want to do the right thing. But this is what's just become the norm. I think that's more what it comes down to. This is the norm. This is what we do. This is what we've been told we do. This is how people get successful outcomes. And so because that's now normalized, that's just what happens. Yeah. So I think we just need to create that new normal again and reset it. Yes, there's always going to be people who commercialize things to make money. And yes, there's definitely nurses and doctors who come into this because they think it's going to be an easy buck. But I would like to think for the majority, it's a bit of a considered choice, but I think there's lack of mentorship and collaboration and, education as to how we do this in a way that's beneficial to both the practitioner and the patient. We've just gone along with what we've seen, and we're not taught business practices in medicine and nursing. I didn't even touch that again. And, my NPs, we talked about business cases for bringing in new areas of access for patients, but we certainly didn't talk about it from a commercial perspective. So again, it's just education, isn't it? And people understanding there's other ways to do things. But I think it's great to push it back to a consultative process. I think it's great to push it back to education. And we can do that really successfully without, having our patients pick something they want on the website. We're putting the cart before the horse, right? If they've already come in and decided what they want, how do you turn around and go, sorry? That's a really awkward conversation. And we have to have those awkward conversations all the time.
Yeah.
And in fact, a lot of training focuses on awkward conversations. What do you say if a patient wants this, but you think they need this? I mean, the fact we spend so much time talking about that tells you that we've put the cart before the horse. If you know what product you want and what area you want, but that's inappropriate for you, that's a tricky place to start from, from a consult perspective. So, if patients come in with an open mind, knowing that they like your value set, they like what you stand for, they like how you educate, and you come in and you showcase the options, you then empower them to make a good choice. That's how treatment planning should work, and that's how it works in medicine everywhere else, just not in our industry.
Thoughts, David?
I can't disagree with anything that either of you have said. I mean, I've said in many podcasts before, I've been part of the problem. I was involved in the chain clinic business model. I'm not saying they're all bad, but I think they have been an impetus for how things have progressed in terms of the commercialization or the commoditization of what it is and what we do in training patients to, as you said, pick a treatment from an advertisement, whether it be Cheeky Chicks or Lips to Love or something like that. It's just sort of been downgraded to like getting a spray tan or getting your nails done, and patients can pick and choose what they want with very limited information, or they've done a quick look on Google and think they're empowered to make those decisions for themselves, or being influenced by what their friends have had done. So I think we have grown so quickly that, and you see this in businesses. Businesses get started, they get a lot of success, they grow, they expand, but the infrastructure and all the support mechanisms and processes haven't been able to keep up with the rate at which the business has grown, and then eventually it just sort of topples on itself because there's nothing underpinning that business. And I think it's the same thing that's happened with this industry. We've grown so quickly that things have just gotten out of hand. And I think you have had people that have joined this industry, as Jake alluded to, who are motivated for different reasons. They've gone and done their degree as quickly as possible. They've transitioned straight out of their degree into a chain clinic, or they've decided to go open up their own practice and used a telescripting service. And they're on their own doing these treatments with very little experience. And I'm not sort of painting everyone with the same brush. I'm sure there are good operators out there that have gone through this process, but I think that this is what happens when things expand too quickly. There isn't all the checks and balances and the infrastructure there underpinning the industry. So, I mean, I think that what's going to happen, and I, get my mentoring clients asking me all the time, like, what's going to happen from here? And my honest answer is, I think we're going to see over the next 12 to 24 months, radical changes in the space. I think you're going to see a lot of people that are going to realize it's not going to be an easy way to make money anymore. It's going to get a lot of people to reconsider whether they're going to open up their own business. If they are passionate about this industry, they're going to have to go and work for someone and gain that experience, gain that patient following. And then if they want to go and do something entrepreneurial in the future, that's going to be a secondary step. So I think we're going to see a lot of people leave. I think we're going to see a rebalancing between supply and demand. I think that potentially prices may go back up, because as soon as demand is more than supply, that's what happens. Those are market forces. And I think in the end, it will probably be a good thing. My only concern is that once you start down the path of regulation, where does it stop? So are we going to get to a situation where people cannot inject unless there's a doctor on site? Can people not inject that aren't medical doctors? Are they, as Jake alluded to, are they going to say nurses can't inject anymore? So that's, I guess, my concern. Like, where does it actually stop? Where do we? Sorry.
I think a lot of that's up to us. I mean,
but who's us? But when you say that, but who's us? I mean, we're so disjointed. Sorry?
Yeah, that I said before. I think every professional body needs, what I can do as a nurse and what's appropriate as a nurse is different to what's appropriate as a doctor. So I think nurses need to lean in, and we've got the CNA who are doing a great job at trying to look at this, but we need to create what those boundaries and guidelines look like within our professions. And then come together as an overarching thing.
Yeah.
But, our professional bodies, we need to showcase to them within our specialty how we can do this safely. So that comes back to us. Again, stopping, thinking, pausing, and actually really articulating and writing down what it is that we do and getting approval for that and consistent agreeance, I guess.
Yeah.
And that's what needs to happen. So we've gone quickly. It's been amazing. Chain clinics have done fantastic things for training. To be honest, they've done great things for, patients to have choice. I don't think it's necessarily a bad thing. But I think, we've grown too fast in some areas that we just need to stop and pause. And now we need to dig into this specialty and go, okay, cool, within a nurse's area, what do we need to do to showcase that practice from a doctor's perspective? Where are the crossovers there? And then really come together to agree. But we're silly to think that each profession is going to be exactly the same. It can't be, because the rules and regulations around what we can do are different. So we do need to lean into our own professional bodies and start that process of regulation there, and then build on that to come together. Yeah.
And I think what's further muddied the waters is there have been commercial reasons that have driven certain actions from different groups. So people sending in anonymous complaints about colleagues in different areas, whether they be nurses or doctors, and sort of tying up regulators' time and resources in sometimes vexatious or frivolous complaints because of a commercial dispute or a certain area of this industry feeling this is their stomping ground, this is their territory. And so I think it's been a number of issues. We've obviously had the media that love to write stories about what goes wrong in our industry. And I think it's been an amalgamation of genuine issues. I think there's been a lot of commercial jealousy that has led to unnecessary noise. And I think it'll be very interesting to see how this plays out. What do you think, Pene?
Yeah, it does. But if people are complaining there's a problem, full stop, you're always going to get those outliers who are going to do that, right?
Yes.
Like, that's just every practice, every business. We see that everywhere. But I did jump onto the AHPRA website when I was looking at the pathway for nurse practitioners. It's really interesting. They've got this incredible big title that says cosmetic surgery crackdown, and we all know that they are looking at it. But in the last 18 months, I've had 713 complaint calls, which is pretty exceptional. And looking at the statement then made by AHPRA, the sheer number and complexity of the complaints make these investigations among the largest and most detailed ever undertaken by AHPRA. We've got a problem. Like, regardless of how you want to spin it, or if it's practitioners dobbing in practitioners or patients ringing up because they're unhappy, that's an extraordinary amount of complaints in one specialty. So they've got to do something. And yes, I think they've missed the mark in terms of patient safety, and that should be more around regulation and how long you need to do general practice, for example, before moving into this. But they've got to start somewhere. And if they can just stop, take everything from a marketing perspective down, we need to pause, and now we need to lean into those professional bodies and start to build it back up again. There's always going to be people who disagree, and there's always going to be people who complain and, want to take business of others. But I do believe for the majority part, most people are trying to do the right thing. We just aren't quite sure how. So that's what we need to work on, is the how.
I wish the regulators would remove the ability to anonymously complain, because that would immediately nip in the bud any malicious kind of competitor type
maybe
issues.
Anonymous from the person that receives the complaint, but not anonymous to the regulator.
Correct.
So
the regulator needs to know who's complaining.
Correct. I think that's the problem. You can just sort of go on and complain anonymously, and no one knows who you are, where you're from. There's no accountability behind what's actually being done. So I think that you're absolutely right. I think if you remove that ability to be anonymous, it would probably make sure that people, if they're making complaints, they're really doing it for serious reasons, and they're happy to put their name behind what it is they're concerned about.
Yeah, absolutely. It's interesting with those 713 complaints I was talking about before, because 214 or something along those lines have been closed or escalated, and about 34 of those have gone to the Healthcare Commission. So that's a serious escalation. And then out of those, again, 147 of those aren't resolved, and they sit in the non-surgical space. So again, there is an issue. 42 of those relate to 41 nurses that are under investigation at the moment. So, if it was something that was really silly, or, it would have been closed down by now. But there's a huge amount of number of people being looked into, for unsafe practices or lots of different various reasons. So, regardless of what we want to say or who we want to blame, we do have a problem, and we do need to start to try and solve that, which comes back to, as I said, leaning into your professional bodies and supporting them to come up with some great protocols and guidelines and governance and scope of practice documents that we can hopefully then take in and say, this is what we believe is fair and true, and then get agreements across, from everybody. But it's not the same. We've got to stop doing that as well. It's not the same for a plastic surgeon versus a GP versus a nurse. It's not. So we can't have one standardized guideline for everybody, in my opinion. It needs to be very specific based to our training, our knowledge gaps, and have a very clear pathway. And I think once we have that pathway, I really hope that AHPRA look at NPs again and go, oh, wow, yeah, this is a serious, specialty of medicine. And we can see a very clear pathway now of learning and how you get to advanced practice in this piece. And of course, we would love to endorse nurse practitioners in the aesthetic space. But at this point in time, it's just not going to happen.
Did they give any flavour as to what the unsafe practices were or the complaints? Because in our, in the webinar with the TJ the other day, it was a very sort of throwaway comment, but one of the motivations for the change was an increase in patient safety kind of issues. I can't remember exactly how it was worded. I just wanted to know, well, what is that? What is that statistic? What are the safety concerns? Because, of course, the industry has grown massively over the last 20 years. And so inevitably we will get higher numbers of serious issues, risks, downtime, and perceived things gone wrong, just as, because the number of procedures is going up. But I want to know, are things actually gone wrong? Are we getting more VOs and blindnesses, for example, rather than not frivolous complaints, but patients, unhappy that they've been bruised, which is inevitable, but you can still complain and go to AHPRA for that if you want to.
Yes, but even VOs and blindness should be on a consent form, which should be spoken about, which should be, consented properly. So from an informed consent perspective. So yes, that would be investigated. It'd be horrible to have, a very serious side effect. But, AHPRA would, I would assume, if they go through the process, kind of go, well, they did all the right things. They've ticked the right boxes. They've used the right safety standards. They've used the right protocols. They've used evidence-based practice. They've consented correctly. The patient was under the understanding of what could go wrong. So they will investigate it thoroughly, I would hope. But I don't know how they define patient safety or what that means. And that's a really good question actually for us to understand, because I certainly think it would help practitioners understand that as well.
Yeah.
And that, was it 791 complaints you said? 713.
How does
that compare to other areas of medicine?
Well, that's what they've said on here. It's the largest and most detailed ever undertaken by AHPRA, full stop. So I couldn't give you the statistics in comparison to other industries, but they've never had to put this much manpower by the looks of this behind, one specialty. And I mean, that's incredible.
I mean, don't forget, we've had a funny couple of years, and 2 years ago when there was this big investigation, mainly on cosmetic surgery, not necessarily non-surgical, there was almost an invitation from the regulator to the public to complain. And fair dues. If there was a serious complaint that you felt too scared to complain about, that invitation is a good, valid sort of route to get some recourse. But at the same time, it may have also encouraged a lot of, frivolous is the wrong word, but any sort of complaint, people might have been encouraged to then complain.
Yeah,
sure.
And I think as well, we need to, I think as well as that, we need to look at what is considered an area of medicine that is not necessary, and people walking in with the expectation they're not going to get bruised, they're not going to have any discomfort, they want a perfect aesthetic outcome. That patient mentality and the expectation, and perhaps that comes back to the way that we advertise ourselves and the expectations that we as practitioners set. But there's a very different mindset between a patient that walks in with a life-threatening illness and walks out alive that has a horrific scar, and the way they feel about that scar, as opposed to someone that was completely healthy and walked out with an outcome that wasn't exactly perfect, but then feels compelled to write a complaint. Yes. So I think that number definitely, Pene, is concerning, but the devil's in the detail. What actually is that number made up of? What are those complaints? Which ones are serious? Which ones are, serious adverse outcomes that have physical or psychological effects versus someone that didn't have their expectations met, that potentially is psychologically unhinged, that shouldn't have a treatment in the first place? I mean, I'd like to unpack what that number actually means.
Yeah, and don't forget, I mean, I've seen Facebook forums where hundreds and hundreds of patients at these cosmetic clinics were almost inviting each other to join class actions and so on. So I just wonder if that number has been inflated by a number of serious cases under particular practitioners. Is it a realistic, real number? Do you know what I mean?
Yeah.
Look, very, very good points. But at the end of the day, doesn't that come back to education as well? If we stop marketing it as being, fancy, free and fun and pick your mix and come in on the day and we'll do what you want. If we talked about the education around, what side effects look like, and the consumers were more aware, our patients, not consumers, our actual patients were aware when they came in of the side effect potentials and what that looked like. Yeah. And that comes back to the way that we've marketed this. Yeah. So again, it comes back to us, really. They're complaining because they think they've, been given a disservice, but maybe it was just something, if they were educated properly, they would understand was part and process of the healing process. I don't know.
Yeah. I think you're right. I think that's definitely valid, but I think that there's no getting around the fact that the psychology of the general aesthetic patient versus the patient that's genuinely ill, they're very different, and the expectations are worlds apart. So I think we're all right. I think we're in furious agreement with each other. I think we're all saying the same thing. It's concerning. It needs looking into. We need to take ourselves more seriously. We need to get rid of all the cowboy practitioners in the space that are ruining it for everybody, and we do need to come together and formalise a training pathway. And as you said, Pene, taking into account people that have come from different backgrounds, who've got plastic surgery degree, someone that used to be an anaesthetist, someone that's a nurse. I mean, they've all got different basic skill sets and training and education behind them, and I think it needs to be taken into consideration. But we do need to unite as an industry, because this internal conflict that we've had is not helping the situation. Yeah,
100%. Pene, you and I are teaching in a couple of weeks together for Allergan, and something that you and I have tried to weave into our teaching, but I guess it's not in a formal way, is not just clinical skills and anatomy and whatever, but it's just teaching people to be ethical, professional, considered, thoughtful injectors. So for injectors listening, maybe not even done their training yet, maybe they're nurses thinking about becoming injectors. Can you just give them a flavour of what you would recommend to people to make them rounded, sort of ethical, professional people, rather than just being good injectors?
Absolutely. First, to what I said before, stop putting the cart before the horse, and it comes down to your career as well. You need to be a good person and have good ethics and good values, and really think about why you want to do this in the first place. What are your own aesthetic biases? What are your own body dissatisfaction issues? What are you wanting to achieve from this? Where is your career going to go? Because then once you've done that and you've thought about yourself and you do put your ethics and values first, then it's about being a good practitioner. So if you're a doctor, it's about being a good generalist doctor. If you're a nurse, it's about being a good nurse. And there's so many avenues in that we forget or put to the side to go into the injecting space. So basic asepsis, for example, basic, human care, wound care, looking at infections, being intuitive on the way that we see our patients, understanding evidence-based practice. I don't know many nurses in the aesthetic space who understand the pyramid of evidence and what's a good clinical paper and what's not, or how to speak to reps and say, okay, cool, you've given me that evidence there, but talk me through these 5 things, or, is it a double-blinded, randomized, controlled trial, or was it not? We don't understand these things because we've forgotten what it's to be a good practitioner is to start with being a good nurse from my perspective. Then once you've got those 2 foundational things right, yourself, your nursing practice, then you can layer that with an advanced skill set of aesthetic medicine, which is everything from understanding, like you said, anatomy, rheology, communication, psychology, all of that stuff sits in that bucket specifically to aesthetics. But you've got to layer that. You can't just jump from, I want to do this and I want to end up being an injector. It doesn't work that way. It takes years of practice and years of understanding, even in your basic knowledge of being, a professional nurse, doctor, whatever, to then add on, how to be an injector. It's the last part. We can teach you the technical skill. It's everything else that comes before that makes you good or great.
Yeah. And I think you've said in the past, you're a strong advocate for nurses going through their training to continue and get some work experience for at least a year or 2 in, hospital or GP or somewhere where you're learning all of those skills, maybe without thinking about it. You're just absorbing that bedside manner and, learning how to look after patients. And often that can be bypassed here, at least in Australia.
Totally. And how to work collaboratively. There's nowhere in, hospital medicine where you're on your own. You collaborate with nurses and physios and doctors and OTs and, specialists and radiographers, and you're constantly in a collaborative environment to get the best outcome for your patient. Yet what we've got here is a whole lot of autonomous practitioners working on their own, and they're not collaborating. So they only have their own ideas and their own knowledge and their own interest in furthering themselves. They're not thinking outside of that box. And, when you work in a hospital environment, you're always being taught or you're teaching others. So you get this amazing ability to open your mindset to new ideas constantly, right? Because someone's always going to bring something new in. So you're always learning. And we kind of stop that. Yes, we go to conferences once a year or so, but just in general, we're not collaborating around our patients' outcomes with people around us as much anymore because most of us work very much on our own. So, little things like that, happen when you're in a hospital setting or a clinical setting. So if you're really serious about getting into this industry, there are so many primary care pathways that would really help you, hone in your skill sets for looking after basic patients. So, even GP nursing, couldn't think of anything better than primary health nursing. You're seeing wound care, you're understanding vaccinations, you're going to see patients with autoimmune, autoinflammatory disorders. You're going to have a great knowledge of all of these medical indications, which a lot of our patients carry through into the aesthetic space. If you think of emergency, you're looking at airway, breathing, circulation, you're looking at all these pathways as well, and just doing a really quick assessment and understanding and looking for red flags. That intuition comes in. So aseptic practices, even taking bloods, looking at cannulation. There's so many things that we can learn in a basic setting, which is going to set you up to be a great nurse, which means you can then layer that aesthetic medicine on top and be really successful in that area as well. But it comes down to being a foundationally great practitioner, nurse, doctor, whatever it is that you are before you come into this industry. And without that, you're not doing yourself any favors, and you're certainly not doing your patients any either. So I would advocate, in my world, Pene's world, at least 3 years of primary care or general practice in some area. And if you're really serious about aesthetic medicine, choose an area of medicine that's going to complement what you end up doing, because not all of the areas of medicine do either.
Can I ask you, Debbie, you employed hundreds of injectors in your time. Did you anecdotally notice a difference between nurses who came straight out of school to becoming injectors and those with that experience?
Yes.
How do you do it?
Oh, I mean, there was definitely an evolution of the people that were presenting to you for jobs within your business. I mean, traditionally, when aesthetic medicine first became a thing, it was people transitioning from general nursing or primary healthcare nursing who had taken an interest in aesthetics but had a wealth of experience behind them. So just in terms of the way that they held themselves, the way that they were able to communicate with patients, the ability to pick up red flags, aseptic technique, understanding the importance of clinical note keeping, patient care after treatment. There was just a much greater adherence to, I think, first principles thinking when it comes to taking care of a patient. And then as the industry progressed and more clinics opened, it became more commercialized. You had people going into the space who just wanted to do injectables and sort of fast track themselves through to this clinic, and they had none of that behind them. And there was a stark difference. I'm not saying all of them, I can't say everyone was the same, but if I was to sort of talk in general terms, there was a noticeable difference in the mindset and just the seriousness and sort of how they saw these treatments and procedures, most definitely, for sure. Yeah. So, I mean, I can't disagree with anything that you guys have said. But Penny, I'd like to get your thoughts on, I mean, we just had a really compelling discussion with a doctor from Melbourne, Dr. Izzy Silla, who is taking a fairly unique approach to treating aesthetic patients, where she's combining regenerative or integrative health with aesthetic patients. And there are patients that she won't even touch with a needle before she's looked at their blood work, looked at their sleep, their nutrition. She works with a number of different allied health professionals, GPs, sports physios, and other allied health professionals, and looking at this patient holistically. And I'm curious as to know what your thoughts are, because to me, it seems like there's a natural union between the way that we look externally and the way our body's functioning internally. So, I think this is the future of where we're going with aesthetic medicine, if I was sort of to crystal ball gaze, but curious to hear what your thoughts are on that.
We spoke exactly about this 5 years ago on the podcast.
Yep. So here we are. It's happening.
It literally just come around. We said exactly this. It's got to be important to look at the internal health and the external health. And, again, from a nursing perspective, you're going to get a lot more experience doing that outside of the aesthetic space in general medicine. So, of course it does. I think a lot of this lifestyle medicine, as far as, making ourselves look better, fits in beautifully to our holistic health. People want to look good, feel good, live longer, live healthier. It's lifespan, health span, all these things that we talk about. It's exactly all of that. So it's great to hear that integrated path is there. And, we do a lot of that in dermatology. Most patients who come in, they want an aesthetic outcome. We are seeing signs of rosacea, or you talk to them about their hormone balances and, I've put on weight and I feel like I look like this. So a lot of what I do isn't just looking at their face and understanding and dictating what they need from an aesthetic perspective. I'm looking at their overall health and saying, okay, cool. Well, autoimmune, when was the last time you had your bloods checked? Let's look about this. And hormones, yes, your skin's changing. It's gotten thinner. You're going through perimenopause. Let's talk about how we can support you through that process and who's going to be the best individuals and practitioners to support that, so we can support your skin health overall. So it's all important, that external and internal piece. So there you go. We predicted it 5 years. So
here we are. I just wanted to just go back to what you were saying about time in hospital, and I sort of just go back to a philosophy that's not mine, but being taught to me by people much smarter than me, was that you become the product of your environment and the people that you spend the most time with.
Yeah.
So if you finish your degree and you're in a hospital with people that are years ahead of you in terms of experience and skills, you're in an environment that is training you to think a certain way, training your instincts to react in a certain way, you will become a product of those people in that environment. So it's not just about spending time for time's sake. It's about in sort of immersing yourself with the right people in the right environment to shape you into the practitioner that you should become.
Absolutely. It's a medical pathway. Yeah. It's a career pathway. And that's how we need to look at aesthetic practice. It's a pathway. And to get on that pathway and to do well within that pathway, there's stepping stones that we need to take. Yeah. Understanding general health and being a good person, and then a good nurse is what you need to start with before being able to be a good or great injector, because you're layering that. Yeah. So I couldn't agree more. Yeah. I think it's really important. And it doesn't have to be hospital, but certainly a clinical setting where it's medically based, with what you said, people above and below you that you can teach and be taught from, and understand collaborative relationships and forge that. I still, talk to a lot of people I work with in hospitals for many different reasons and refer to them. So, building that network is so important for your practice as well. And
for sure. You raised a good point, in terms of not just being the recipient of information, but being the communicator of information. When you're teaching someone something, it actually makes you understand what it is that you're teaching better. I've had a number of instances where I've sort of been imparting knowledge on somebody, whether it be in this space or something else I do externally, and you think, wow, I kind of explained it to myself as I was explaining it to somebody else, and it actually starts to make you more cognizant and aware of what it is you're doing. It's a really interesting phenomenon. You almost become better at something by teaching someone else who doesn't doesn't have that skill yet.
And there's nothing like pointing out what you don't know when someone asks a question. You go, oh, gee, no idea what
I need to go research it.
They need to go and look that up or do some more education themselves. So it keeps you honest, I think, when you've got junior staff members asking you questions, and that's how it should be. Yes, we're autonomous, but we still need to work collaboratively to get the best outcomes for our patients.
And so maybe just a parting piece of advice or some thoughts from you. So obviously the pathway to become an MP, if you are involved in the aesthetic space, is closed for now. Maybe that'll change in the future. We don't know. So what's your advice to people that are listening to this who may be disappointed to find out that they're not going to be able to achieve that higher level of educational recognition within the aesthetic space? So what should they do in your opinion? What's the pathway they should go down, learning from your experiences, things you might have done differently and sort of where we are now?
Think of your long-term aim. If you're 20 years old getting into this industry, if it takes you to 30 to become an NP in the aesthetic space, that's really not that long. It might feel that long when you're 20, but, think about cultivating a great holistic view of your career and, do a new graduate year in a medicine field that's going to complement aesthetics. So go and work in a primary practice and learn everything you can and get to a senior level with that. If you're really serious about this at this point in time, learn everything you can about that base, that base first, and then move into the aesthetic side. So I would say go into a hospital primary care setting, do your new graduate year within that, build your skill set, learn to work collaboratively, understand everything you can about holistic health for patients, and then slowly introduce the aesthetic side into your practice and then build both together. And then from there, if you did want to go to the MP path, yes, you would be looked at really openly and, and at the same time, you're going to build a much stronger, narrative to your career, full stop.
Absolutely.
And final question, kind of taking it a step back, what do you say to people who want to just become an injector? There isn't the formal pathway and there are a million courses. So what's your sort of couple of bits of top tips of what you would say to those people?
There's no such thing as becoming just an injector. To be an injector, you need to be a good nurse. And to be a good nurse, you need to have a holistic view of how to care for a patient. So becoming an injector is an add-on to a foundational nursing career. And you can do that in so many ways that partner with aesthetic medicine. If you're really serious about it, look at dermatology, look at so many different areas, plastics, nursing. There's so much that you can do that complements that space that's going to give you a much better foundational nursing practice. That's what I would say. Don't see it as it's a part of being a great nurse. It's an add-on. It's not the foundation of nursing practice.
Good answer. I like that.
Perfect. Well, thank you so much, Pene. It's been educational chat. It's always, humbling to sort of talk to you. I mean, I've known you for such a long time, probably close to 20 years now since we first met, and it's been amazing to watch your journey. You've always been one of my favourite people in this space, and as always, you sort of hold yourself with a lot of integrity and say what's on your mind, and congratulations for all your success, and thanks for contributing to our podcast and educating our listeners.
Couldn't agree more. And I look forward to seeing you in a couple of weeks where we join forces to try and impart some knowledge on what are deemed advanced injectors. I don't know how we define that, but we'll have a lot of fun. And thank you for sharing all your knowledge, Pene. We really appreciate it.
Thanks for your time. I appreciate it too.
For our latest news, follow us on Instagram at Inside Aesthetics Podcast. If you want to get in touch with myself or David, follow us on Instagram as well at Dr. Jake Sloan and David_Inside Aesthetics.
Join our Patreon for invaluable business and injectable education. Get access to our global community of like-minded professionals, live and interactive Zoom sessions, hints and tip videos, webinars, and more. Head over to www.insideaesthetics.com/Patreon for more information.